Welcome to the class. Can you hear me, guys? Am I visible and audible to you guys? Okay, hi. Right, so I'm seeing that it's live now. So today we will be talking about the image quiz for the general surgery part 2. Okay, so can I hear it from you guys? Uh, I see Farhat Hussain is here. Hi. Right. So let's move on and let us talk about it straight away. Okay. So now we have the audience. We have 8 of us watching. So without wasting any further time, let us talk about it. Okay. So what is being depicted in this particular image? Okay. So guys, can you help me with this? What is being depicted in this particular image? Is it notes, sills, poems, or seps? Okay. So what is the answer? Can you tell me what is being depicted in this particular image? Okay. Can you tell me what's the answer? It's A, B, C, or D? Just post your answers, guys. So, what's the answer over here? Right, it is sills. So Richim is saying it is sills. Yes, definitely it is sills. So what is it? It is sills. That is okay. So single port basically laparoscopic surgery. Okay, single incision laparoscopic surgery. So we know that one of the advantages of doing a laparoscopic surgery is that we have a less scar. I mean, the scar length is less. But if there is someone who doesn't want any scar in the abdomen, so what we can do is we can just go for a single scar, incision just below the umbilicus, and then we can enter into the abdomen with the help of a sills port. So what is this sills port? This is single incision laparoscopic surgery port. Okay, so what is in this particular port? There is a one single incision laparoscopic surgery port, and through this you can insert 2 to 3 trocars, and then you can operate through these trocars. So in this particular image what you're seeing is a sills. What is this notes? Notes is again something which is important. So what is this notes? Notes is natural orifice, kind of a okay, so endoscopic surgery. Okay, so this is natural orifice. In this, what you use natural orifices. So what are the natural orifices? We can use mouth, we can use anus, we can use vagina. Why is it used? So please understand, it is not basically used. You will not insert your instrument through the nose or mouth or something like that. You will not do that. Why do you use it? One of the main reasons you use it is to deliver the organs. So let's say the example that you have operated on the the cholecystectomy or something, or maybe a hysterectomy or something, and then you want to deliver the organ. So these natural orifices are used to deliver the organ, and this is basically the main importance of notes and notes. Okay, so please understand this. This is a natural orifice endoscopic surgery, that is notes. What is this poem? This is basically a acronym. This is basically a treatment which we use for achalasia cardia. So what is this? Peroral endoscopic myectomy. So this is used for achalasia cardia. Okay, and what is this seps? Can anybody tell me what is this seps, guys? A very simple thing. Where do you use it? So Farhat, Richim, can you tell me where do you use this seps? Right? Can you tell me, guys? Anybody can comment it? Where do you use the steps? Right. So it is basically used for varicose vein. Okay. So it is used for varicose vein. So what is this basically? This is subfacial endoscopic perforator surgery. Okay. So it is a subfacial endoscopic perforator surgery, and this is where we use seps for the varicose vein. Right. So this is our first image for the day. Now let us talk about this. So if I ask you what is the diagnosis of this, what is this particular kind of a dressing or a closure? So can anybody tell me? For the vascular. So yes, Richim, now you know it is basically used for varicose, right? So vascular surgery, good. So it is basically used for varicose veins, right? So can you tell me what is the diagnosis of this particular image? Can anybody write on the comments? So Richim, what is the kind of a diagnosis of this? So no brainer, this is basically a negative suction dressing. Okay, so basically this is a negative suction closure or a dressing of whatever. Okay, so this is a negative suction closure or a dressing. Yes, it is a vacuum assisted closure dressing. Good. And yes, the answer is in fact B. So what I was trying to ask you is, what is the negative pressure is being generated here? So the negative pressure which is generated in this is minus 125 mm of Hg. So please understand this, okay? So what happens? You create a negative pressure. So what does this negative pressure do? It takes up the whatever the serosanguinous discharge or whatever it is there, it is sucked into this dressing and it is transmitted out. So what happens? In the local environment, there is not much of a pus or a necrotic tissue which is present over there, and because of this, the wound healing is in a better fashion, in an earlier fashion. So please understand this. So this is basically a negative suction closure dressing, and this is used, like the negative pressure which is generated in this is minus 125 mm of Hg. Okay, so I hope you understand this. Okay, this is again an important MCQ. This image was shown in your AIMS, so this particular value can be asked in your NEET PG entrance. Okay, right. Now, a patient had a testicular swelling and he was operated. We did it orchidectomy was done, and we saw the following gross specimen. So can you tell me what kind of testicular tumor can be present? So I'm waiting for you guys. Please answer. What kind of testicular kind of a tumor can be present over here? So I assume there is a bit of lag between what I say and what appears on your screen, and that is the reason why I think you guys are answering a bit late. Okay, so I'll just wait for you guys. What is the answer to this particular question, guys? Okay, what's the answer, guys? Please answer. Okay, so Farid is up with the answer. She it's B. Is it so? Okay, well, what do you see in this particular gross specimen? You see a solid cystic component. Okay, so what do you see? Yes, so what do you see? Basically, it is a testicular tumor where there is a solid component and there is a cystic component also. So yes, no doubt, the answer here is teratoma. What is a teratoma? It is kind of a testicular tumor, or it can be tumor anywhere in the body, which is derived from ectoderm, endoderm and mesoderm. And the characteristic feature of teratoma is it is heterogeneous. It means it has a solid and it has a cystic component. So no doubt, very, very clear question. The answer to this particular question is teratoma. Now, if at all they would have shown you the gross specimen with a homogeneous kind of appearance of the testes with kind of no deformation in the shape of the testes, then it would have been seminoma. Okay, so the homogeneous testes, that is kind of a seminoma. I hope you understand this. Okay. Right, now moving on. So a patient had has a bilious vomiting and CCT has shown the following image. Now I want each one of you to answer, guys. Now this is something very important, so I want you to answer. So here what you have a patient who is having a bilious vomiting, and a contrast enhanced CT scan of the patient has been shown to you. So can you tell me what is the diagnosis of this particular patient? Okay, so Richam, Farhat, Indra, can you tell me what is the diagnosis? Now you need to broaden your vision and you have to look at the particular CT scan in a better way. Okay, so please tell me what's the diagnosis. I'll just zoom in for you because I assume that you might not be able to see it very, very properly. So, well, what's the answer? Can you tell me, guys? Anybody? I'm waiting for your answers, guys. So yes, definitely there is a lag actually, and that is why I have to wait a bit to get your answers. Okay, so Indra is saying it is C. Farat is again saying it is C. Why it is C, guys? Why do you think it's C? Annular pancreas. Why, Indra? Why annular pancreas? What are you seeing on the CT scan which makes you think that it is a annular pancreas? What do you think? I told you that you will have to broaden your visions for this. So please understand it is not annular pancreas. The answer is not annular pancreas. So Richam is saying it's A, Sakshi is saying it's B. Well, very good. Sakshi, you are absolutely correct. Okay, so answer is in fact B. Okay, so Sakshi, you're right. Good. The answer is B. Can you tell me why it is B? Can you tell me what sign do you see on this particular CT scan, CCT? Sakshi, can you tell me why did you choose it B? Well, the answer is B because it is what is being shown on the CT scan. It is a whirlpool sign. So what do you see here? You see a whirlpool sign. So what you're seeing over here, you're seeing a whirlpool sign. Okay, so please understand. So what is a whirlpool sign? You all know what is a whirlpool. So this is a whirlpool, right? So this kind of a sign is there. So in this, the white color thing, what you're seeing, this is artery, and the intestine and all, they are basically getting wrapped around this like a whirlpool. Okay, so that is why the answer is whirlpool sign. I hope you understand this. Okay, so not the target sign, not really a target sign, it is a whirlpool sign. Okay, it is a whirlpool sign. Okay, did you get it, guys? Can we move on? Now the experience is not very great today because I have to wait. There is a lag between it, and if I just keep on saying it, it will not help you guys. So that's why I have to take it a bit slowly. So yeah, let us kind of start. Okay, so let us move on to the next particular question. Right, so here there is a patient who was advised a CT scan for some other condition, but there was an incidental finding and was detected along with it. So the image has been shown. What is this incidental finding? So can you tell me what is this incidental finding which you see on this particular image? Right, the lag is much today. It is close to around 30-40 seconds. That is real bad. Okay, so I'll have to look at it why it is happening, but I'll just wait for your answers. Okay, so what is the answer to this particular question? Anybody, can you answer it? Right, so I'm waiting for your answer, guys. B, horseshoe kidney. B, horseshoe kidney. Very good. So yes, definitely the answer is a horseshoe kidney. So it's a simple question, but yes, don't confuse it with a cystic disease of the kidney. Please understand. And yeah, this is the CT scan which I just wanted to show you, because you must have seen the X-ray of the patient with a horseshoe kidney. But if you take up a kind of a CT scan, it will look like this. Okay, so this is basically the isthmus which is joining, and definitely this is a horseshoe kidney, no doubt. So most of the clinical, like the clinical features, most of the patients of the horseshoe kidney are asymptomatic. Okay, so that is why it is an incidental finding. And what is the kind of the incidence of horseshoe kidney? It is present in 1 in 400 people. So every 1 in 400 people will have this horseshoe kidney. Okay, so good, that's the correct answer. Good. So moving on, so let us talk about this. Now, what is the diagnosis of this particular patient? So can you tell me what is the diagnosis? Is it a retroperitoneal fibrosis, pelvic lipomatosis, retrocaval ureter, or a PUJ obstruction? Can you tell me what's the diagnosis of this particular patient, guys? So I'll just wait for your answers and then I'll tell you what's the answer. So what is the diagnosis? So I'm really sorry, today there is a lag and I have to wait a couple of minutes so that at least you attempt this question, you form an answer in your mind, and then I am able to tell you this. So I can see the lag is close to 40-45 seconds today. I'll have to look into it why it is there, but I'll get it checked. Okay, so well, what's the answer, guys? So now you can see what's the answer. Anybody can put up what's the answer? So Indra, PUJ obstruction. Richam is saying PUJ obstruction. Okay, Indra is saying D, PUJ obstruction. Sakshi is saying C. The level of the horseshoe kidney, I'll tell you that. Okay, Ria. Okay, PUJ obstruction, retrocaval ureter. Well, I'll come back to you, Ria. Just wait a minute, I'll come back to you. Don't worry. So answer to this particular question is in fact retrocaval ureter. Now I fail to understand why many of you are choosing a PUJ obstruction. PUJ obstruction doesn't look like this. Okay, so what is the characteristic finding which you see in here? No, it's not a lily sign. It is a fish hook appearance. Okay, so what is it? It is a fish hook appearance or a fish hook sign. Okay, so it is a fish hook appearance or a fish hook sign. What you're seeing in here, this is a fish hook appearance or a fish hook sign, and this is a characteristic feature of a retrocaval ureter. So here there is the inferior vena cava, and usually what happens, the ureter goes in front of the inferior vena cava. In these particular patients, what is happening? The ureter is going behind the inferior vena cava. So this is what is called as a retrocaval ureter. Okay, so I hope you understand this. Okay, so this is basically a retrocaval ureter. Okay, so this is a fish hook appearance which we get in patients of retrocaval ureter. Understood, guys? So well, this is something which you need to remember. Just remember this name. It is also called as a Shepherd-Crook deformity. Okay, or right, so just understand this fish hook ureter, the Shepherd-Crook deformity, that is referred to as a retrocaval ureter. Now somebody asked me what is the level of the horseshoe kidney, so I'll just tell you what is the level of the horseshoe kidney. So please understand, the isthmus of the horseshoe kidney lies at the level of L3 L4. So the best option which you can choose is, it is basically L3 L3L4. Don't go for this L1. Okay, so the best option is L3L4. Please understand this. Okay, so the isthmus of the horseshoe kidney lies at the level of L3L4. Okay, so did you understand it, guys? Right, so this is again a very important MCQ. Okay, so I hope you got it, Ria. I hope you got it. Okay, so the level of the isthmus is L3L4. Now let us move on to the next question. Okay, so let us move on to the next question. Okay, so the next question is, what is the best position of a patient to insert the Ryles tube? So what is this? This is basically the Ryles tube, and the question is trying to ask you, what is the best position in which you can insert this Ryles tube? Okay, so I'll just wait for your answers, guys. What do you think? What is the answer? Right, Priya. Okay, so what's the answer to this particular question? Anybody, guys? So Sonak, Sakshi, anybody? Sitting. Okay, everybody is up with the sitting. Very good, guys. So it means that you have revised the AIMS questions correctly. Good. So answer is in fact a sitting position. So please understand, Ryles tube, the best position to insert the Ryles tube is in the sitting position. This is the first MCQ. What is the other MCQ? It is basically, what is the length of the Ryles tube? So if at all you want to calculate the length of the Ryles tube, how you can calculate the length of the Ryles tube? No. Farhad, please understand, it is not B. This is a repeat question from AIMS. It hasn't already been asked in AIMS, and it was a study which was conducted by the AIMS people only, and they found that the preferred position to insert the Ryles tube, it is in the sitting position. So this is a repeat question from AIMS. Please don't do it wrong. Okay, so yes, definitely the answer here is sitting position. Now if I ask you, how do you calculate the length of the Ryles tube? So how do you calculate the length of the Ryles tube? It is calculated by measuring the distance between the nose, the tip of the nose or whatever, from the tragus, nose to tragus, and tragus to the Zippy sternum. So the length of the Ryles tube, it is calculated by measuring the distance between nose to tragus and tragus to the Zippy sternum. And this gives you the length of the Ryles tube. What is the length of the Ryles tube which you have to put in the patient? Okay, so right, this is the things about the Ryles tube. Now another important thing about the Ryles tube is, what is present on the Ryles tube? There is a dark kind of blue colored radio opaque line is present on the Ryles tube. Okay, so sometimes they ask you, what is this dark blue color, green colored line, what does it indicate? So it indicates that it is a radio opaque marking over the Ryles tube. Why it is radio opaque? So that you can take up an X-ray and you can see where is the Ryles tube. It has reached the stomach or it has gone into the lungs or somewhere else. Okay, so this is the reason why you have this radio opaque marking on the Ryles tube. I hope you understand it. Okay, right. Now what is the next question? So next question is, what is the flow rate? Okay, so this is based on the IV cannula. So what I'm trying to ask you, what is the flow rate of this IV cannula? So what is this IV cannula? This is a green cannula which you have. And if I want to ask you, what is the flow rate for this IV cannula? Can you tell me what is the answer, guys? So I'll just wait for your answers. Can you tell me what is the flow rate of this IV cannula? Anybody, guys? So I welcome all of you guys. I think we have close to 30 people watching us at this moment. So I want each one of you to participate. So it is just a drilling session for you guys. I know that you have already read it. I'm just trying to drill you and trying to recollect it. Okay. So while inserting Ryles tube, head should be flexed or not? Yes, it should be flexed. Okay. So it should be flexed. So in the sitting position, the neck should be flexed. It should be flexed here. Okay. So is it a 16 gauge cannula? Oh, Richmond, really? Don't do that. Please don't do that. It is not a 16 French cannula. And what is the answer to this particular question? So I'm getting the options as if B and D and B. Okay, so Simon is the one who has answered it A. It is good. Okay, so please understand, guys. Yes, no doubt it is a 18 gauge cannula. So green. This is basically the 18 gauge cannula first and foremost. And what else? What is the flow rate of this cannula? The flow rate of this cannula is 90 ml per minute. Please understand this, guys. This is important. Okay. So I don't expect you to memorize each and everything. That's fine. But this is a cannula which we use very commonly. So you should have a fair idea about this. Now let's talk about the recent question which you had. In the AIMS you have been asked which is the preferred cannula for the severe dehydration. So see, understand, there are no specific guidelines for the severe dehydration, but yes, because the flow rate of the gray cannula, it is around 180 ml per minute. So that is why you will have to prefer a gray cannula in patients with severe dehydration. But if we talk about patients of polytrauma, okay, so if you have a patient of a polytrauma, in these patients, the preferred cannula to be inserted, it is a green cannula. Please understand, 18 gauge cannula is the preferred IV cannula to be inserted in a patients of polytrauma. Why? Because in patients of polytrauma, the recent ATLS guidelines say that you have to insert 2 IV lines on one in each arm, and this has to be a 18 gauge cannula. Okay, so please understand this. Now, in the next slide, okay, so I did not cover it, but yes, you can have a look at this. Okay, so please understand this. What about the pink one? So it is a pink one, that is a 20 gauge, that is a pink cannula. So what is the flow rate of the pink cannula? It is close to 60 ml per minute. And what about the flow rate of the gray cannula? It is close to 180 ml per minute. Okay, so if at all you want to remember the flow rate, I will advise you to remember the flow rate of only the 3 cannulas, that is the green one, that is 90 ml per minute, and then gray, that is 180 ml per minute, and pink, that is 60 ml per minute. Okay, so I'm really not happy with the experience today because of the lag, but I hope you are able to cope up with this. Okay, so well, yes guys, so let us move on to the next particular question. Right, now this is again something very important, and you should understand this. So can you tell me what is the spot diagnosis? I'll just wait for a couple of seconds for you to answer. Okay, so please tell me what is the spot diagnosis of this particular thing? Well guys, yes, please tell me what is the spot diagnosis of this particular thing? Now, well, yes, you now know this, so please tell me what is the spot diagnosis. Fast guys, fast, please. Anyways, there is a lag from because of the internet issues. Please tell me what is the spot diagnosis. Boyer-Reeve syndrome. Why Boyer-Reeve syndrome? So I'll just give you an idea. What is this? This is basically a colonoscopy. Okay, so yeah, my bad. It is basically a colonoscopy. So what is it? It is a colonoscopy. Diverticulae. Okay, punched out ulcers of the esophagus. Okay, esophageal perforation, esophagus. Okay, now can you tell me guys? Okay, well, I will not wait for more time. It is basically diverticulae. Okay, so what is it? It is a diverticula. Okay, so this is a diverticulosis. Okay, so please understand, it is not a punched out ulcer of the esophagus. Please understand this, guide. It is not the punched out ulcer of the esophagus. Please don't do it like that. Okay, so this is not a punched out ulcer, this is a colonoscopy. And what is this? This is a diverticula. So important thing is, they will not ask you that, but you should have a fair idea how do the diverticulae look on the colonoscopy. They look like this. Okay, so please understand this. Okay, and if at all they will ask you this, they will ask you this barium enema. Okay, so they will ask you this barium enema. And what do you see here? So what is the kind of what is the sign which you get in here? You get a sawtooth appearance. Okay, sawtooth appearance. Please understand this. Okay, so this is very important. Now this is something very important they might ask you. Okay, so what is this? This is a sawtooth appearance which you see in patients with diverticulosis. Please understand this. Okay, important image, very important image, can be asked to you. Okay, right. Okay, right. Now let's move on to the last particular thing. So name the test which has been this patient has been subjected after the parotid surgery. So you performed the parotid surgery in the patient, and after that you subjected the patient to some particular test. What is this test? I want to know what is the name of the test. Can you tell me what is the name of this test? I'm waiting for you guys. Please tell me what is the name of the test. I'm waiting for you guys. Can you tell me guys what is the answer? Talcum powder. Why will you apply talcum powder over there, guys? Very good, very good, very good. It is a starch iodine test. Very good. It is a starch iodine test. So what is the starch iodine test? This is basically a best test to use to diagnose basically the patients of Fraze syndrome. Okay, so what is this Fraze syndrome? Because of the aberrant communication between the parasympathetic fibers in the auriculotemporal nerve during the surgery of the parotid, there can be a cross innervation, and patients may come to you with a sweating while the patients chew the food, and this is what is a Fraze syndrome. And the best test to diagnose it, it is a starch iodine test. Very good, guys, very good. Okay, how do you manage these patients? You have to go for antiperspirants, and you can go for botulinum toxin. Okay, so you can also go for a botulinum toxin. Okay, right. So this is about the starch iodine test. So this by this we covered the 10 MCQs for today, the 10 important images for the today. Let me tell you about the upcoming sessions. So tomorrow at 1 o'clock we have a session at instruments, and tomorrow at 4 o'clock, sorry, at 4 p.m. we have a session on sutures. Okay, so tomorrow at 1 p.m. we have a session on instruments, and tomorrow at 4 p.m. we have a session on sutures. Okay, so right, tympanic neurectomy, definitely yes, we can also go for the viridian neurectomy or a tympanic neurectomy. Very good, guys. Yes, you can definitely go for that. And yes, so I hope to see you guys tomorrow. If at all you guys are free. In the instruments, we will again be discussing the MCQ parts. We will be covering around 10 to 12 instruments, and then we'll be talking about the sutures in the evening. Okay, so thank you so much for joining with me today, guys. And yeah, thank you so much for joining with me today. I hope this session was helpful to you, and hope to see you tomorrow. And yeah, in this session, I tried to cover a bit of the difficult images, a bit of the ectopic images, just for you. You should have a broader outlook towards thinking towards those particular things. Okay. So as I always tell you the same thing, I'll tell you the same thing again. Just stay strong. Just keep reading. Just keep revising the 80% of the most important topics, and you will be good to go. Okay. So all the best, guys. Happy studying. And if at all you're not following me on Unacademy, please follow me. In the description you'll find the link to my page. You can come there, you can follow me, you can check the upcoming courses which I am planning out, so you can definitely come there and you can have a look at that. Okay, so thank you so much for joining with me today. I'll take up a couple of doubts if you guys have, and yeah, if you have any doubts, please do ask me. I'll definitely try to answer it. Okay, so just wait for a couple of minutes. If you have any doubts, I'll take up, otherwise you're good to go. Right, so all the best, guys. And yeah, if at all you have a bit of anxiety related to your exams or something, you can check up a video I did yesterday on the final thoughtful words about NEET PG by Dr. Pawan. You can have a look at it. And this basically I've tried to tell you what is the thought process which you might be going through, and if at all you can fight it through, it will be helpful for you in the upcoming NEET exam. Okay, right, so if you have any doubts, just post it. I will take it up, otherwise yeah, see you tomorrow. I'll just wait for 2 minutes and then I'll be off. Okay, any doubts, guys? Any doubts? Right, so see, understand, just keep on revising the 80% of the topics. That will be enough. And right, just keep reading till the last date. Okay, so just keep on flipping through the pages, just keep on going through your notes. That will definitely help even in the exam. Okay, so I think you guys don't have any doubts. That's completely fine. Let's hope to catch up with you tomorrow morning, as I've already told you. Tomorrow afternoon, rather, 1 p.m. we have a session on the MCQs and instruments, and tomorrow evening at 4 o'clock we have a session on sutures. Okay, so many students had requested about the sutures, so yes, I'll definitely take that up. Okay, so thank you so much, guys. Have a great time. Happy studying. Signing off. Bye.